Okay, thanks to Pramod for giving me this opportunity, and Saravanan did a very good talk. And I'm going to talk against ILM peel in RD surgery. We all know that ILM peeling started as a part of macular hole surgery and became a standard, step in a macular hole surgery. But over the past decade, we have seen that it has become something that is done in almost all the vitrectomies, and probably I feel it has become a fad. I feel you have to prove yourself by peeling the ILM that you're a vitreoretinal surgeon. It has reached that stage. So people are peeling the ILM left and right and saying that once I go into the eye, I don't come out without the ILM. This is the statement. But what's the evidence? I think Saravanan did present this evidence. There are many studies in the literature. He also quoted some. What we have to remember is most of them are retrospective and there are very few prospective studies. And this again is the study which we are going to talk about a little bit more detail. This is a meta-analysis which Saravanan alluded to. They pooled 9 studies. Remember, only one of them was a randomized control trial. Rest of them are all retrospective. So they essentially said the same thing. Then the peel group and the non-peel group, they looked at the ERM formation and the visual outcome. There was no difference in the success rate, no difference in the vision recovery. The only difference was that ERM formation was prevented by ILM peel. And this overall in the vision, again, there was a little difference because in 4 studies in this and a meta-analysis, vision was better in the peeling group. And in the 4 other studies, vision was worse in the peeling group. So the final word about the vision being better in the ILM peeling group is yet to be said. So the one thing we have to understand and notice in all these studies is that in spite of more ERMs in the non-peel group, the visual outcome was the same. What does it mean? It means most of the ERMs in these patients were not visually significant. We all know that ERMs can exist without causing vision problems. We see so many idiopathic ERMs where the vision is 6/9 and we don't touch them. So similar is the case in post-RD surgery ERMs too. We don't go around removing all of them just because they exist. So conclusion of the meta-analysis, it reduces the incidence, but no vision, no difference in the visual outcome. So is it enough to justify ILM peel in all the cases? Let us look at this study. Saravanan did not want to quote this study. This was done as a prospective randomized trial, 30 eyes in each group, vitrectomy with silicone oils with 6 months of follow-up. They studied the OCTA and ERG, multifocal ERG, in addition to regular vision. And what did they find? They find that the vision was worse off in the peel group, of course, and the vessel density in the superficial capillary plexus was worse off in the peeled group compared to the non-peel group. Of course, ERM formation was more in the non-peel group. And finally, the P1 amplitude of multifocal ERG was worse off in the peel group. So here there is evidence to say that there is a definite effect of, deleterious effect of the peeling on the retinal structure and the function. So in conclusion, ILM peel during RD surgery can reduce ERM formation, agreed. But none of these can affect the vision to a great extent. And peeling an ILM is technically challenging. I know PFCL can be used, but it's an additional step. You're going to introduce PFCL. Normally, I don't like to use PFCL in a simple rhegmatogenous RD. I do not use PFCL, in all the cases. So it actually adds about 15 to 20 minutes to your time. And there is a potential for iatrogenic damage. Especially, I can imagine a novice surgeon who is not experienced trying to peel ILM. You can easily cause a retinal break close to macula, and end up with much more problem than you started off with. So we need larger studies to identify. I'm sure there are some eyes which benefit from ILM peel. Would you like to peel ILM in a macula on RD? That's what I would like to ask Saravanan. Would he peel in a macula on RD? So I feel ILM peel is definitely not on in all cases. Select them judiciously. And thank you for your attention. Thank you.
Thank you, Dr. Murlidhar. Thanks to both the speakers for being within time. Dr. Saravanan, a quick comment from you before Dr. Mahesh takes over.
As article in the IJO, Indian Journal of Ophthalmology article, was a prospective study where he showed that not only the ERM, but they were able to reduce the risk of recurrent retinal detachment also in the ILM group, in the group where they peeled the ILM both in the macula as well as the peripapillary zone. So that is one prospective study which showed success. And all these negative effects of ILM peel are very subtle and rarely affect vision, which I showed because we have been doing this peeling for all macro holes for so long. And even though this was one of the reasons why temporal flap was advocated, we hardly see as a visual deterioration in these patients following ILM peel in macro surgeries. Those are all like 6/6 and 6/6 parts or 6/9 parts. When you're not really worried about addressing the ILM in such good vision, especially in macula of RDs, what's the big what do you say, trouble or reservation in such cases? That's what I wanted to say.
Thanks. Dr. Mahesh, your comments?
Dr. Saravanan, you have not still answered Dr. Murli's question about whether you'll peel in macula on. Yeah.
Probably no.
Yeah. So Dr. Murlidhar managed to put across his arguments very effectively without showing provocative photographs of actresses or any other images. So yes, but
the very fact that he needed to use them means his arguments are weak.
Yeah, but also like he very effectively, very cleverly didn't talk too much about recurrence of retinal detachment. So that was one of the positive points for peeling the ILM. So even the meta-analysis shows that like if you peel the ILM, the recurrent RD rate seems to come down. That's one of the reasons why some of us do peel the ILM nowadays. Yes, macula on RD, yes, we would probably not peel the ILM for the risk of decreasing a subsequent ERM formation. But ILM peeling definitely does have a role in identifying a subtle epiretinal membrane, which is causing, or rather the very early PVR, which is not very obvious. So you can peel the, like I stain the ILM and start peeling it, that kind of gives us a handle to the subtle PVR, which we can peel also. That seems to be like a positive factor for peeling the ILM. Yes, we may not be peeling the ILM in every patient of regularity, but with a subtle, probably grade B PVR, peeling the ILM seems to help in decreasing the rate of recurrences, is what I would think.